Oh, I know. It's gonna be so cold out. We usually do this before we start, but I'm gonna do it at the beginning. And so this is great for all of us. Write down 3 things you're grateful for. So there we go. That'll keep you fit. All right. So good morning, everyone. We're taking up S-197, the primary care bill, which is a top priority in this building. And I think in the administration and everywhere else. So we're going to hear from folks so we can make some progress on the bill. And then we'll be moving on to a couple of other bills that we've been looking at that are also critically important to us. So we'll start this morning with Dr. Ann Morris. Thanks for being here. We're going to introduce ourselves once around the room for folks who don't know us, and then we'll start our testimony. Go ahead.
John Molly from Orleans District. John Benson, Orange District.
Ginny Lyons, Chittenden Southeast.
Where's Ibaraki with Chittenden Central?
And Senator Ann Cummings, who will be in from Washington County. So thank you for being here. We'll go right ahead.
So good morning, everyone. Thank you for allowing me the opportunity to speak today. I've met some of you in the past, but as a reminder, I'm Ann Morris. I'm a family physician who practices in Milton, Vermont. And I've worked with the UVM Family Medicine residency for a decade in primary care. And as of May, I became the Associate Dean for Primary Care and AHEC at the Larner College of Medicine. I'm also a board member of the VMS and the VTAFP. So as always, please consider these as my words and not those of my employer. But introductions aside, I'd like to start with some reflection on where we are today and how we got here. As these reflections often go, it was 4:30 on a Friday afternoon. I'd already been in clinic all day and had worked through lunch. And my patient looked at me and said with tears in her eyes, "Why does everything have to be so hard?" We were talking about caring for their shoulder, one that had been injured after a fall. The pain was keeping them up at night, and despite previous recommendations from us to rest and take it easy with some home exercises, they were continuing to use their arm at their job in the local nursing home. I was recommending formal physical therapy to speed recovery, and they said with a bit of anger, "It's just so expensive." Another patient came to see me for a preventative physical and asked me to do everything that I need now and in the near future because she plans to go without insurance in 2026. Her work in preschool education, a job that requires an undergraduate degree in early childhood development, doesn't pay enough for her to afford the premium increase for insurance on Vermont's healthcare exchange. And finally, several of my Medicare patients are coming to see me at out-of-network costs because their plans have all changed this year, and premiums are, in some cases, now higher than their monthly Social Security checks. But they desire to stay with the provider they've been working with for years and who knows them best despite the costs. I had a little bit of a hard time composing my thoughts into what I wanted to say to you as a committee this morning. In my world, this feels like a high stakes conversation. And I need to convince you that really investing in primary care is the right thing to do for our patients, our providers, and our healthcare system. It feels high stakes because we are trying to please everyone. And we're proposing, in order to do this right, to invest more money into primary care while trying to reduce the money that's going into the healthcare system as a whole. But I'm going to try anyway. We can all agree that investing in primary care reduces total healthcare dollars spent and improves the lives of people. By now, you're all familiar with the statistics that for every $1 spent in primary care, it saves the system $13. It does that through relationship building and trust. Did you know that a provider needs to have almost 70% continuity with their patients in order to actually improve health outcomes. And that the longer the continuity relationship lasts, the greater the impact on reducing resources spent on urgent care visits, emergency room, and hospitalizations. A study published in Norway actually showed that when that relationship lasts upward of a decade, it reduces emergency room visits and hospitalizations by 25 to 30%. This directly speaks to creating an environment that is easy to access for patients while being affordable and sustainable for providers. At AHEC, we review and update a roster of open positions within the state board. As of December 2025, there were 79 open primary care positions in the state. We all have seen the predictions on how this number is going to continue to rise. It is not easy to recruit and then retain providers in Vermont. And for that, Vermonters suffered decreased access to care through longer wait times and the burden of having to travel farther for their care. There are many reasons that it's harder to recruit providers to rural places. It starts with having a smaller pool of people coming from these areas with interest in becoming primary care providers in the first place. It worsens by not having enough clinical training in these rural areas to increase provider confidence during training and make them fall in love with the communities. And it's compounded by high educational debt and the fact that rural areas traditionally pay the lowest salaries in a field that already has significantly lower salaries compared to their specialty colleagues, upward of $100,000 as an easy difference. Addressing these workforce development challenges takes a longitudinal approach that starts with introducing students to careers in health as early as middle school and continuing these exploratory opportunities all the way through undergraduate education. It continues in medical school and residency training through early and frequent exposure to healthcare in rural communities and culminates through a variety of programs to reduce educational debt burden that help to attract and then retain primary care providers in these communities. Some really great examples of these works include things such as CSHIP, the Governors Institute of Vermont Institute of Medicine, the upcoming Maple Mountain Consortium, Rural Family Medicine Residency, the AHEC Medical Student Incentive Scholarship at ELCOM, and the Vermont Educational Loan Repayment Program for Healthcare Providers. I'd be happy to come back and talk about those in more detail.
You will.
So, once we get the providers to Vermont, we have to work hard to create a system where they can afford to practice and where they feel that they're valued by the community and the systems within which they're providing care. This is the part of S197 that's become exciting to me. In the bill, we're trying to talk about increasing total investment in primary care. We're talking about investing in primary care teams so that they can meet individual patients where they are, help them make their diagnoses more manageable, and provide the short-term follow-through that providers whose schedules are booking 3 to 6 months out can't provide. In order to do this successfully, I'd like to comment on a couple of things from this bill. The proposed primary care spend rate feels bold at 15%, and it would be if we were starting in 2027. By waiting to enact this until 2029, we will again already be behind the proverbial 8 ball, and it will take years of data collection and negotiation to raise this rate. For true primary care reform to be able to reach all Vermonters, we need to have payers and practice, and we need to have all payers and all practices participating. Primary care is a team-based sport. We can't achieve value-based care and meet quality metrics alone. It is extremely important that we increase our investment in initiatives like the Blueprint Community Health Teams to allow practices to provide that integrated care in patient-centered medical homes and to keep people out of the ED and help them meet their short and long-term health goals. Paying for services provided in healthcare is difficult and comes in many forms such as fee-for-service and capitated models. We're going to see a mix of it in reality. It's the focus on a per member per month PMPM payments, like we see with Blueprint, and monthly payments like we saw through OneCare's comprehensive payment program that will help to make a measurable difference to these practices. Finally, we need to acknowledge that regardless of practice type, federally qualified health centers, independent practices, or hospital owned, we are all seeing the same patients with the same degree of risk, the same degree of illness, and the same social and societal needs. All practices need the advantages of reducing administrative burden, including prior authorizations. A primary care provider in Middlebury ordering a CT scan has the same credentials and the same burden as one providing care in Randall. All practices, regardless of type, also need access and investment in technology, like ambient AI technology for documentation, and resources to bring things like point of care ultrasound to primary care practices across the state. It keeps people out of the hospital. In summary, I want to acknowledge that these concepts are complex and broad, and yet by tackling them, we have the opportunity to improve the health of all Vermonters and reduce the total cost of healthcare in Vermont in a meaningful way by making a bold, long-term investment in primary care that provides the right care at the right time in the right place. It gives practices financial stability while reducing administrative burdens and allows for innovation that meets the needs of the individual communities in which those practices reside. It also creates an environment that not only attracts but retains providers in their practices by naming the value that their services provide to their patients and their communities. Thank you.
Thank you very much. And I don't have any questions. We're going to hear testimony this morning, and then I know that you're under the stress of getting back to patients, so we won't keep you, but we will at some point want to hear about AHEC, since I understand that significant funding was left out of the governor's budget for AHEC, which is a personal concern of mine. So we want to come back into this room and look at that. Thank you for your work on it.
Thank you very much.
Thank you for everything. We need your testimony. Sent Callista, so we'll have it online. Thank you.
Great. Thank you.
All right. Next is John Sorian. The blueprint. We'll just follow along on the agenda that we have. Also, Sarah Rosenberg. Thank you both for being here.
Thank you for having us. One moment. So,
Right?
yeah, you ready?
Okay, we are.
Okay. For the record, I'm Sarah Rosenblum. I'm the interim director of healthcare reform at the Agency of Human Services.
John Sorian, Executive Director of Blueprint for Health Agency.
And we are gonna say some words. We have a written statement that we are prepared to send to you if you haven't received it already. So you will get a written copy of everything we're going to cover today. The Agency of Human Services believes strongly in strengthening primary care, and there is a lot of overlap between the goals of S197 and the goals that the agency has for primary care. So we're looking forward to working with you and continuing to work with you on this bill. Specifically, we're looking forward to working with you on determining the appropriate timing and legislative framework for S197, because we have a significant opportunity underway already to modernize the Blueprint for Health through the Rural Healthcare Transformation Program with the federal government right now. I will turn it to John just to do kind of a brief overview of the blueprint. I know you all got a 101 from him last week, but just as a refresher.
So the Blueprint for Health is nationally recognized, promotes high quality care
including advanced primary care, specialty care, community-based services to positively affect the health and well-being of Vermonters. And thank you, Dr. Morris, for mentioning our community health teams. At its core, the blueprint gives the agency of human services the operational structure to direct payments to practices to support their efforts to improve access and quality. And the blueprint's successes are achieved when that funding is coupled with the community health teams that were mentioned previously and can embed specialized clinical staff and practices in communities.
So you've heard testimony from the agency, Joel Olson, about the rural healthcare transformation a few times. But I think overall, and we haven't had time to just talk specifically about what's in that application related to the blueprint. So, which is a lot. So we've made some pretty significant commitments to the federal government related to changes to the blueprint through our rural healthcare transformation program application. Namely, we proposed doing three things. One, modernizing the payment model that is core to the blueprint. Two, examining the standards for advanced primary care with a particular lens for access to make sure that the quality payments that the blueprint provides to practices are aligning with access and other measures of quality that we want. And then third, developing a payment structure that reflects these standards and consolidating all of Blueprint's payments, which we'll get into in a little bit more detail, into a single payment with the hope that that will help bolster Blueprint's longstanding multi-payer history that has been somewhat challenging in the past. So right now, Blueprint has different programs that some payers contribute to some programs. They all contribute different amounts. And we're hoping that through this consolidation that we've proposed in RHT, it'll be $1 amount that you're paying comprehensively for all of Blueprint services. And it'll be easier to negotiate with payers for participation. Okay. I'm going to talk about those three things a little bit more specifically. And I will note, I don't know, you may have had an opportunity already to look at our rural healthcare transformation application. If you have, I think you'll see that there's definitely still things to figure out, like specific methodologies to figure out within that application. And I do think a core part of what we hope to do over the next year is work closely with stakeholders, including the Vermont Steering Committee for Comprehensive Primary Care, to figure out those details. Okay, so getting more into the specifics we do have now from the application. I mentioned above reassessing the primary care medical home requirements for access under the blueprint. That is an example of something that still has to be determined, like what specific access requirements we might be interested in. But just as examples, having after hours or weekend appointments, having remote patient monitoring capabilities, telehealth, or same day appointments for existing patients, that type of reform. I spoke a little bit already about aggregate payments across all of the different Blueprint programs. So just as to say more concretely, you all may be familiar, or you heard from John last week about the different components of Blueprint. That includes hub and spoke, community health team payments, practice payments, payments for specific initiatives like the Pregnancy and Pension Initiative, and this would lump all of those into a comprehensive Blueprint payment. And then lastly, as part of our RHT application, we secured a significant amount of funding for new payments for the Blueprint program. There are three payments I'll highlight. The first one is a community health team per member per month payment for chronic disease management and prevention. The second is a practice per member per month payment for that increased access. So we talked about potentially revamping the access standards. Also want to make sure that practices have the financial support to maintain those standards. And lastly, a primary and specialty care coordination per member per month payment. So I think right now, probably a lot of this work is already being done by primary care practitioners and that they're trying to coordinate care with specialty care providers, but there isn't necessarily a payment for them to do that. And that this would further incentivize them to coordinate care with specialists and to be adequately reimbursed for that. Since we're talking about this kind of phases in the rural healthcare transformation program, I think it's important to point out the timeline of that program and the timeline of our commitments to the federal government. So it is really important that we execute on our commitments in this program this year so that we can secure funding for the remaining 5 years of the rural healthcare transformation program. What that means specifically is that by August of this year, we need to provide a report to CMS that describes our progress on implementing these commitments. By October of this year, we need to obligate all of our funding from federal fiscal year 26. So that's that $195 million you've heard about. All needs to be quote unquote obligated, which means it has a place to go and a contract has been signed and it's been approved for that landing place from CMS. And then all the money actually has to get out the door by September 30th of 2027. So the work that I just described above, the access changes, the payment changes, the in addition to the new payments, the restructuring of the payments, all needs to happen now. And we're under significant time pressure to perform in order to get more funding from the feds for future years of the program. The last thing I'll say is as part of our rural healthcare transformation application, we also had to provide an evaluation plan for this work. So part of what will be assessed on to determine future funding, in addition to implementation progress, is whether or not we've made progress on specific metrics. So I'm sure in this bill, your goal is for primary care providers to feel the difference of this funding and feel like the system is improving. And I just want to highlight that we have committed ourselves to actually making a difference. We need to show that these reports are having an impact on population health and on the system here in Vermont. So overall, thank you very much for giving us the chance to speak with you today. I will reemphasize, I think we very much agree with the committee's goals of S197. I think the question is, what is the appropriate timing and framework to do this work, given the significant work that will be underway this year with the blueprint and through our rural healthcare transformation program dollars.
Is that it?
Yeah.
That's it for both of you? Okay, I was waiting to hear John's story.
He's here if you have
Just
questions.
reiterate what Sarah
Okay.
said, we're
I do
very
have,
engaged.
I do have some questions, that I think then the committee may also want to ask some questions. So the rural health transformation grant, obviously it's grant, and then within that, my understanding has been that you'll be sending out RFPs, requests for proposals. So some of what you're talking about will come from practitioners and clinics and others to access the operational fund change. So that, so that's one question. And then it goes to blueprint. Will it only be for the blueprint folks, or will it be for folks in the clinical world who are transitioning to a community health?
Sure. Thank you, Senator Lyons, for your question. The blueprint per member per month payments specifically for chronic conditions like congestive heart failure, asthma, that payment will not be, in my early view right now, I can't predict the future if all these things come to be, that will be a practice very similar to the successful mental health integration we did into primary care, what we call an attestation. We will do these things and we will be measured, and the dollars would then flow once those attestations were signed. So that's different from a request for proposals model. And that form of increasing the per member per month amount will follow not only for the community health team for those chronic conditions, but also for the payment that we come up with for access, increased access for the mental health integration, because we need to fill that gap, as well as the specialty coordination that Sarah mentioned, and the potential. And again, I want to emphasize that potential initiatives for technology enhancement are available and are described in our initiatives as available to all practices. And in one of them, it emphasizes independent practices. That would be, and again, I can't predict the future, that would be more based on, I think, the model of requests for
Grants.
yes,
Yeah.
requests, we're requesting this, but those community health team enhancements, the access both to the base payment and to the community health teams will be on that attestation. We'll have the same types of sessions. We have the full mental health integration to get the input, describe things, have questions, and then those attestations will flow out
So,
back to us.
yeah, so
That's quick.
no, this is good. That raises another question, which is, if funds are going out to the Blueprint folks and the mental health expansion or however that happens, then within our bill, we have a date certain by which everyone becomes the Blueprint,
Mhm.
so to speak. Are there sufficient funds within the rural health transformation grant over the period of 5 years
Mm.
to fund those payments? Have you done sort of an analysis of the fiscal impact if all of our primary care folks become what's in the bill, become community health teams?
The fiscal analysis is dependent on what the negotiations finalize in terms of the dollar amount. So that is the first step that we will do when we know what that dollar amount that's negotiated with the federal government that I think Jill spoke to in this committee, that process. That's we need to know those numbers.
That's true. I think, our 195 has been approved, but the line items have
The
not.
line items.
Got it.
The line items.
Good.
But the other thing I want to highlight is, we will be making changes to our budget during this year over year. So if, for example, a bill did pass that would have an impact like that, like saying everybody would join the Blueprint program, we would undoubtedly have the opportunity to adjust our budget to accommodate that.
Okay, and so then my other question is, in the bill, we're looking for a sustainable funding process for our primary care going forward. It sounds like this grant is really a first step to operationalizing payment reform, but it doesn't have within it sustainable funding pathway, which we're going to try to include in our legislation.
And that's, I think, where we want to work with you.
We need to work together.
For timing and blending of those center lines.
Yeah, I will add that as part of our overall healthcare transformation application, we had to include a sustainability plan in that. The work that we outlined here for the Blueprint, I think very much sets us up if Vermont chooses to participate in the AHEAD model, which includes a primary care component. And we did speak to AHEAD as being a pathway to sustainability for much of our overall healthcare transformation initiatives.
Wind back briefly,
Yeah.
a head model may sound new or a refreshment for folks who are here.
Yes.
And
The AHEAD model, which stands for Achieving Healthcare Efficiency.
equity, so we changed it.
They changed it from equity to efficiency,
Affordable.
affordable,
It's a really good, it's a great acronym.
I don't know. The federal government loves acronyms. So,
Okay, we just,
yeah. So Vermont, was accepted to participate in the EHEC model, in 2024, under the Biden administration. That, federal model is a cooperative agreement, which means that it is an agreement between the state of Vermont and the federal government, that required negotiation to get to an agreement. That agreement was signed on the last day of the Biden administration last year in 2025. And since we signed it, the Trump administration has made a number of changes to the EHEC model, and we will have to renegotiate and sign another agreement. So that is why I speak to whether or not Vermont chooses to participate in the EHEC model, as we'll have to renegotiate. We could spend all day talking about the EHEC model, but the main components of the EHEC model include a hospital global budget, component, a primary care component, and newly under the Trump administration, a geographic entity component. So there is overlap with what's in S197, honestly, and trying to move the primary care payment in the state of Vermont to more of a value-based payment that is very much reflected in the EHEC model in its new form, which includes 4 different primary care payment pathways that providers can choose between, that basically run the gamut from fee for service with the little bonus payment all the way to basically full on value-based payment.
so there is a payment model in there, and the global payment, hospital global payment is something that we've also been looking at separate from our heads. So it does jive with counties.
Yes. And the one thing I'll add, just from a timing perspective, is if Vermont chooses to participate in the EHEC model, we would do so beginning in 2028. So something to think about in the context of the timeline of this bill.
Okay. Thank you. So you were. Is there anything else? I stopped you in the middle, so.
No, we're good.
Right, so I guess for us, I understand the Rural Health Transformation Grant will do a great deal to support the regionalization that's going on with the Act 68 transformation work. Very much with the primary care work that's embedded in this and embedded with the advisory committee that we put in place. And then, as you have said, timing is important. I think so. It's critical for us that we have something coming out of this committee before crossover, and then the House will look at whatever we send them. We need to have some harmony structured with this. We can't depend on the Rural Health Transformation Grant to do everything that needs to happen. There are a lot of policy decisions here. And then there is, of course, the sustainable funding piece that's critical. We have some testimony a little bit later on that. So, and then we have Tom sitting behind you, and I'm thinking, but we also have quality metric analysis. That's so critical, as you said, for how we measuring our population, public health, population-based improvements. Yeah. And specifics will be important in the bill. This is the first time. Questions? Liddy?
I got the 500.
This is, it's not simple. I would appreciate your sending, your testimony,
Yes.
but also if you have other information that helps us understand what you are doing with RHT. I know we're all in this together, but some further information would be helpful. As I know the money isn't there yet, we won't know for a while, but when that comes forward, we want to know what does that support? And how will it support transformation? Where?
Yep.
Yes,
Can do.
Senator,
I just want to make sure I understand.
uh-oh. Look at them.
50,000 foot level, let's say, right? This is basically taking money through insurance providers. I'm thinking through my head, Blue Cross Blue Shield, maybe Medicaid, maybe Medicare. Creating some kind of funding system through the blueprint, it sounds like to me, going to the primary care providers. And then, also somehow adding in the rural transformational dollars as well, but the part I'm concerned about on that is these are one-time dollars.
That's a concern,
Um,
because once you give it out,
I know,
there are expectations. So the question about how do you make it sustainable? We don't want to put it up here when it should be here. And how do we fund it? Exactly the question.
okay, and the money's going, I think it says monthly in the bill to the primary care physicians, which is good for your business, I would say, bank. Getting more money than current,
But so we don't lose them.
yeah. No,
Maybe- Yeah, no, yeah.
But it seems to me, this is basically, this section of healthcare is becoming a universal. It's becoming universal
It could be.
for
Yeah.
primary care physicians. So
Could just,
that kind of where I'm.
I think that the opportunity with the federal government has to be maximized. And I think Jill spoke to that the other day. I think the opportunity for Vermont with this bill and the work that we want to do with BMS, with Jen, with you all, is to really make sure we leverage all of those things. And then we get the timing and the order right, and the statutory and the policy aspects right. And we want to do it well, quickly. But I think your 50,000 foot level sort of big description is in the ballpark.
In the boom, I didn't hit a home run.
It's in the ballpark. It's in the ballpark. Did you want me to say it?
Oh, what is Stu? It's like-
Ground rules.
Ground rules. All right.
Senator, that raises some questions. The rural transformation federal grant can't be used to pay salaries, so that money can't go to primary care physicians. It can be used to buy equipment. I love it. That systems, okay, and the problem with trying for years, we know, because we've lost primary care physicians. If you're in a rural area and your patients are primarily on Medicaid, you can't survive. And so we've been, but our rural areas are primarily poor. So we're trying to find a way to allow physicians to survive with reasonable comfort. Because if you become a specialist, you make a whole lot more money. And so the whole thing is, how do you not everyone wants to live in Raleigh.
Why not?
I don't know. They come from New York City and they say it's lonely.
Best skiing in the country.
That's right.
Well, when they're tonight, I'll send them home. Anyway,
Can I try to get some of that, or
yeah, just.
Can
Yeah, of course. Yeah.
I really appreciate your comments. Senator, you've clearly been listening to Joel when she comes to testify.
I'm a money chair.
The rural healthcare transformation dollars cannot be used to pay for salaries, as you said. In the context of the testimony we just gave, because the blueprint is the services within the blueprint are not currently reimbursable, we are allowed to use the money to pay for these per member per month payments I laid out. I also want to add, though, that a significant portion of our rural healthcare transformation dollars are related to workforce. But that we could spend a whole hour going through those.
Well, we will get to
And
that.
we will get to that, but I appreciate your comment related to the workforce need. And certainly we can come back at another point in time and walk you through all those different initiatives as well and the funding for that and rural healthcare transformation. I don't know, you,
You hit it.
okay.
That's right.
No, it's helpful. This is good. I think everyone's starting to get into the funds. Good. Thank you.
Thank you for having us.
Alicia, did you want to add anything to the conversation?
I don't have any additions. I'm just here for question and answer support if needed.
Do you have any dollar figures for us or fiscal health or?
Not today.
All right.
Can I ask a question?
Yes, you may. Thank you.
Bill Langwell, Joint Fiscal Office. The all-payer, sorry, the blueprint payments went away. They were tied to the ed model negotiation. Right now, we're paying ePrint pure state dollars. Is that part of the new ed conversation?
100%.
2028? Trying to reconcile how ePrint would be, payments would be through temporary through the RCP or how they'd be and no longer be state dollars, but it would be some planting versus, so I'm confused on that, high level.
No, it's a good question. Again, I think we could change the budget as we go along. So if we end up participating in the ed model and that negotiation goes well and we get to, which this is, I would say, priority area for all the signatories on the ed model agreement, is that we get Medicare participation in the blueprint. And if we achieve that, then I think we can reassess our rural healthcare transformation dollars so there isn't a supplementation issue. But for now, I think we want to, cover our cover blueprint at least for the next 5 years. We don't know what's going to happen in the ed model negotiations.
And we can use RSTP for that.
Exactly.
Thank you for that question. Okay. And if you don't mind, when you're sending in your testimony, if you could add a comment similar, responding to Nolan's question.
Okay.
It's very helpful.
Yeah, sure. Happy to.
All right, great. All right, good. Thank you.
Thank you.
And this is not the last time we will see you. I'm sorry. We'll be that. Tom Boris is here, Tom.
Yeah.
Thanks for coming, Ted.
It's proud of me. Right.
All right.
Good morning. Good morning.
Good morning. Well, it's good to see you and we're glad you're here. I know it's a difficult time. There's stepping away from one care, but I would just like to say for folks in the room that the work that you've done is really outstanding. Appreciate it very much. And so if you could just maybe give us your testimony and then we'll see where we go.
Sounds great. All right, and to those who know me, great to see you. To those who don't, my name is Tom Boris. I'm the CEO and CFO of OneCare Vermont. OneCare is an administrative entity that managed ACOs going back to 2012, and just concluding business at the end of 2025. So we're here to speak to S197 and the payment reform initiative described within. I had personal experience in that. My team and I developed and operated a program that we called the Comprehensive Payment Reform Program, CPR for primary care. It's a little bit tongue in cheek, the names suck. Since 2018, and it's very similar to the model that is described in this bill. So I have lived experience on the administrative side of this program. When I was thinking about what to say here today, I think it's first to say, I think that this is great. Clearly, the CPR is a program that I still care about a lot. And it did a lot of really good things, independent primary care practices. But I also just want to shed some light on the administrative effort it's going to take to make this a success. So I think what I'll do is start with the goals of the CPR program, what we're trying to do with it, because I think they're very germane to this bill. Probably important to note first, and then I'll shift into just lessons learned, having administered this for a number of years, 7 years, and what I think it's going to take to make this a home run. All right, first, for any of these payment reforms, my primary goal has always been to move business, finance, revenue generation back and move patient care forward. And I think it's important to recognize for primary care practices of all types, they're both businesses and healthcare delivery organizations. So to the extent that we can reform the way they're paid and the way their business works and make it easier, that energy can be redirected into patient care. So payment reforms don't always do that, but that was a core purpose of this program for us, running through OneCare, was to simplify the revenue generation, make it more reliable and stable. They knew how much they're going to get every month, the payment date, and hopefully that alleviated some of the business side stress, and they could invest that time and energy into patient care. So that's always been a priority of mine, whether it's hospital global budget payments or fixed payments, or the CPR program, is to try to simplify the business side and enhance the patient care. Second is to invest in primary care. And share many of the thoughts that were articulated earlier today. If we can invest in primary care, I think there's a lot of positive downstream impacts that come from that. And using this platform, this fixed payment idea, was a way for us to do it. So we come up with a financial model. We would also link to the total cost of care trends. I'll talk about that in a moment. But one of the goals and the aims of the program was to increase how much primary care practices receive relative to fee-for-service. And at the end of 25, we were at about 150%. So they're getting 50% more than they otherwise would have received on average under fee-for-service. And I think that's a great thing. There's a lot of literature and research to suggest that it is a high value investment. The third is this type of model approach can be a great platform to develop incentives that hopefully get everybody moving in a similar direction and prioritize areas of focus that we all believe are high value and important for our healthcare system. And an example of that within the CPR program was in 22 or 3, we offered a higher reimbursement tier to practices that had integrated mental health supports. And they could do that in different ways, gave some flexibility. It could have been a contracted psychiatric nurse practitioner that they had 2 days a week, could have been a partnership model with the designated agency in their area. But if they had some sort of a way to offer mental health supports to their patients, basically through the primary care practice, we were willing to offer a higher reimbursement rate. And just about every practice took us up from that, and they developed the model. So I think that this kind of chassis or this framework can be really effective to help steer the priorities of the healthcare system and primary care. So next, I'm gonna, those are the goals of the program. I think it was successful, in my opinion. Of course, I'm biased a little bit, but we grew the program from 3 practices, organizations in 2018 to, I think, 19 was the most we had towards the end. So clearly that showed me it was a good program. They talk to each other, and I think the growth is a really strong signal. We also saw through data that the CPR practices often outperform their peers in quality measures and areas that we're focused on. So that was also good evidence of the success of the program. So my role in it, not a physician or a healthcare delivery person, but finance lead in many ways, but it takes a lot to administer these programs. So I'm going to go through a list of thoughts I had while reading this bill. And I think it's just important for us all to know these thoughts going into it to make it a success. Because I'd love to see this program be a success and live long past OneCare. First, a program like this needs very active management. The healthcare system around us changes all the time. We've seen many changes through our journey at OneCare, where there's mergers, practices add providers all the time, and they lose them, and maternity leaves. We've seen hospitals divest of practices and they become independent. We've seen that go the other direction as well. There's lots of change that occurs, and these practices, if they're in a program like this, need somebody to talk to call and say, hey, this is going on in our world. business happens, right? And somebody to help solution. And I would always tell practices, if you have a change coming, let me know ahead. Keep your secret, but we can help solution get out in front of it so that this type of fixed payment or payment reform framework works with their change and doesn't get in the way of the change. So that is to say, there needs to be a team of people who are running this program, who are there for the practices and help support them, answer questions, and just ensure they feel taken care of in this model. Second, something I've learned through time on this part of these pay reforms is that the spirit of the program matters, how it's run. Payment reforms on paper are neither good nor bad. It's what you do with them that matters. And you can take a hospital global budget and make it a great thing for hospitals. You can make it complete bigger. So it's really important to think about how it feels. I've had to learn this. I'm a finance person, often very quantitative, but how the programs feel does matter. It feels like this is a good thing, a support, working with the practice, you're going to get better engagement, better buy-in. That goes back to having that administrative team to run it and ensure that this works as well. A little bit more technically here, I think one of the biggest barriers to getting this program up and running and being success for a long period of time is going to be on the payer side of the equation. You need payer partners to work with you and collaborate. Medicaid, Vermont Medicaid is probably going to be your best friend. I'm not saying that just means but
Well, we know that. We have high regard.
me too. They've been a great partner with us and have really helped us work to make the CPR program possible. So I have a lot of confidence there. Medicare is a totally different thing. They really don't offer any customized arrangements. AHEAD is out there as potential. There are a lot of other public stock off the shelf Medicare programs, MSSP or Reach, things like that, that have potential for some payment reforms built into them where they can turn off the fee-for-service reimbursement and instead pay a monthly fixed payment. That's not going to be easy. I think it's going to be really difficult to find that arrangement with Medicare that will make this kind of program work. Commercials, tricky. Candidly, in my experience, it's been a difficult area to work with to get everybody on the same page and work together. I think the legislature could use this power to compel commercial insurers to participate. But beyond just the compelling them to play ball, you really want them to be engaged and a partner in it, but in a way that supports the initiative, but also stays a little bit hands-off. I think any initiative like this, you need to give the entity running it some independence to figure it out and work it. Too many cooks in the kitchen, it's going to be a distraction and make it difficult to operate this program. So wrapping all that up, really the first step to make this thing possible is to have upstream arrangements with payers that can make this technically and practically work. Shifting around a little bit, I really like the idea of no co-pays in the patients in the primary care setting. First thing that came to mind is one is we just have to remember to backfill that revenue stream to practices as they need it. And then second, it's an area worth monitoring, and feedback from providers is going to be way more important than anything I have to say today. But one worry is that there aren't any co-pays. So some people showing up in the primary care practices for things that aren't don't require an office visit, perhaps. So it's worth monitoring if it's really free to go to the primary care setting, making sure that people go there for the right reasons. I think will be important. Next on my hit list here, we built in a linkage to the total cost of care as well in the CPR program. And the reason I like it is that over time, healthcare costs grow. Primary care reimbursement hasn't kept pace. So we saw a 5% increase in the total cost of care. We did not typically see a 5% increase in how much primary care was receiving. So I like building a linkage there that as the total cost of care grows, primary care keeps pace. That seems like a really good idea. I will say technically it's very nuanced. Their payer mix matters. So for example, your average Medicare patient has a much lower percentage of their healthcare costs in the primary care setting because of the amount of higher acuity costs that exist outside the primary care. So payer mix will matter. Kind of interestingly, when you look at primary care spend on a PMPM basis across payer lines, Medicare, Medicaid, commercial, they're all kind of similar. There's not a huge variation there. So there might be different ways to think about that. But in general, I really like the linkage to some sort of total cost of care as well as to ensure primary care is specific. data. This one's gonna be tough too. So this relates to the payer, side of the equation, but for whomever runs this type of program, you're gonna need data. Total cost of care data will be really important if you're trying to link primary care reimbursement to that in some way. But I can't speak to monitoring in a second. You just have to have data to ensure you're getting the outcomes you want here and to troubleshoot and problem solve along the way. With all good intents, there's plenty of mistakes that happen in the payment reform realm. Medicare will make mistakes. Will pay fee for service for claims that should have been zero paid under our arrangements. You don't even know that's happening unless you have data. So there needs to be some way to get the data feeds, total cost of care feeds to whichever entity runs this, because without it, they're going to fly blind. So keep that on your list of priorities. Figure out the data solution so that this type of program can work. That has a linkage also to quality measures. I think there should be some sort of a quality component whenever we're investing in any part of the healthcare system. It's reasonable to me to ensure that there's some accountability for outcomes. I like the idea of claims-based measures from an administrative standpoint. It's like a lot of these here. I will say though that some of the best population health measures require clinical values. So that's probably a phase 2 or a step 2 initiative, but things like diabetes control, hypertension, you need clinical values. You can't fully assess that with claims alone. But in general, I think to simplify the administrative burden is a good idea, and in my view. Very similar to many of the concepts I just articulated, there's got to be active monitoring of the program using the data. You can't set this up on January 1st and let it run for the calendar year and then look backwards at it. Like I said, things happen along the way. There's problems, there's changes, and they're much easier to fix and address if you catch them early. Whenever we found a problem that existed for too long, it's became difficult. The magnitude of change, whether it's financial reconciliation or something like that, just get bigger and bigger and bigger. So having active monitoring that catches issues, catches problems really quickly is going to be really important to make this smooth and successful for practices. My last 4 are a little bit more conceptual and less tactical. I just want to say that a program like this is a big responsibility for whomever runs it. And this is something I took very seriously at OneCare. When a practice says, okay, you can turn off my fee for service, but I'm now counting on you for my monthly cash flow, that's a big deal. And early on in OneCare's journey, we wanted to build a small balance sheet so that we had some flexibility if there was an issue. We didn't get a payment from a payer in time, or there's some other cash flow burp in the process with the payers. We need to make sure we can take care of practices and have some flexibility to, short term, maybe supply some cash flow or something like that. But it's a big deal for these practices when they agree to turn off their ordinary and well-known revenue stream and rely on something else. So it's important that there's somebody running this type of program who's there for the practices, can help troubleshoot, and even has access to some cash if needed to smooth things out if or when the problems occur. Iteration is going to be really important. The model that we rolled out in 2018 is quite different than what we ended up with in 2025. Every year we made adjustments. Too much change is a problem, but we often got really good feedback from participants. We had an idea, we thought it was great, but they would bring up something really important and credible. So next year, say, that was a really good idea. We're going to make this adjustment to the program. The point in saying this is in whatever bill language you land on, I recommend making sure there's enough flexibility to allow the administrative entity, whoever runs this, to make those iterations through time. Get participant feedback. The feedback from your providers is going to be really important, and just create space to do that. Similarly on innovation, this is a great platform to test new ideas out. Giving that entity some leash to do that, try new things, I think is really important. That's how we learned at OneCare to try something, thought it was a really good idea. Sometimes it worked great, sometimes it didn't. That's the process. That's how you learn and make these things better over time. And at really high level, I think the universal truth in payment reform, and many cases in life, is that if you solve one problem, you create another. And the exercise in this is, okay, great, we've moved practice off of fee for service and address some of the problems with that concept or idea and create a new paradigm. Through time, over years, you have to ask, are the new problems better than the old ones? Sometimes it's clear, yes, we're in a better space now. Sometimes, no, we have to say, actually, you know what, the new problems are worse. And sometimes you just don't know yet. But I think it's really important for this committee, state government, and whoever runs this to think about that. When you shift this paradigm to a fixed payment model, there are new risks that exist. And how do you evaluate and test those to make sure that this is a net positive engagement and program over time? And is value add to our state, the providers, and the patients this sort of thing. So to wrap all this up, I think, yes, I think this is a great idea, clearly. I care a lot about the CPR program. But in reading it, I'm keenly aware of the administrative lift it's going to take to make this a success. I think that's my biggest message here is to make sure you resource the work necessary to do this properly, because if it's not resourced, I think there's real risks for practices that goes through.
Thank you. And it would be great to have your testimony sent into Callista, so we have it on our record. So a lot of details in there, specifics, some of which belong in the bill and some belong as the administration of all this happens. So thank you.
But great.
Quick question.
There's some questions too.
No, thank you for your work.
It's my pleasure.
You're teaching us a lot.
Yeah, sure.
Yeah. So we have online Wayne Altman, who's a professor and chair of family medicine from Tufts University. And is he up there? He was.
Hello?
He'll be back on. Okay, good.
Hello? Hello?
He's here. He's here. So, well, Dr. Altman, and you know, before you begin, just a couple words to those of us on the committee and in the room. We understand that you are going to present some ideas about funding, payment reform, the bill. Significantly, we need a sustainable funding source and an overall process for keeping our primary care system alive. So your thinking on this is very welcome, and I know we'll be continuing with this discussion as we go forward. So thank you for being here, and please introduce yourself for the record, and then we have your testimony and we'll listen as you go on.
Well, good morning. Thank you so much for inviting me to be here. Thank you, Senator Lyons, and to the Health and Welfare, the Senate Health and Welfare Committee. My name is Dr. Wayne Altman. I'm a family physician in Massachusetts, and I'm chair of the Department of Family Medicine at Tufts Medical School. And I'm the leader of a grassroots movement that has been working for 7 years to establish primary care legislation in Massachusetts. We're very excited. We think that 2026 will be the year that we will pass historic legislation, but I would love Vermont to beat us and do it first. And so I have some slides to share with you all, and I'll try and get through them quickly. And I invite you to interrupt me and ask questions if you have any. Even though I talk fast, feel free to interrupt me. I don't believe I'm allowed to share right now. Is there a way to allow for sharing?
We're working on it.
Okay, thank you so much.
Did you do it? Okay, you're set.
Very nice. Can you see those?
Yes, this is good. You could, if you want to expand them to the whole screen. Right now,
I do.
There you go. Perfect. Thank you.
Okay, so we call, what I'd love to do is share with you the legislative effort we've been working on in Massachusetts. As I read about S197, which is really fantastic legislation, it was really amazing how much we have in common. Without comparing notes, we've really come to a very similar place, which is very heartening. We call our legislation Primary Care for You, or PC4U. And the burning platforms are, I think, quite familiar to you. Primary care access is very problematic. The cost of healthcare is exorbitant. It bankrupts individuals, families, businesses, and frankly, it's devastating to state governments and municipalities as well. There are huge health disparities. And one thing that's interesting is you may notice if you or a family member needs to see a mental health professional, most of them are cash only or concierge, if you will. And that evolved about 20 or 30 years from now. And right now, if we don't fix primary care the way we're paying for primary care, in 5 or 10 years, that's where we'll be with primary care, that the majority of primary care will be cash only, concierge. And imagine if there are health disparities now, imagine how much those will be exacerbated. Further, there's a huge problem with primary care pipeline. As my friend likes to call it, it's a parched primary care pipeline. What's interesting is this study from 2013 that looked at the average salaries of primary care doctor as compared to a specialist. That's the blue line, and it goes up and down over the years. The red line is medical student choice for primary care, and it's in parallel with that. So I have a good friend who said to me, it's not that complicated, Wayne. You need to put more money into primary care and pay people more, and medical students will come. When you get to about a ratio of about 70%, medical students flock to primary care. In addition to fixing the pay, we have to fix the job. The administrative burden is off the charts, and to get people to come, we need to fix the job and fix the pay. In terms of the access crisis, though, it's not just that people aren't coming, it's that people are leaving. In Massachusetts, I don't know the data in Vermont, about 1/3 of primary care docs are over 60. People are retiring early, people are leaving their profession, people are decreasing their hours, shifting to concierge. And every time people leave or decrease their hours, they leave the same workload behind for the rest of us, which furthers burnout and creates this vicious cycle. So this is a real crisis. And in Mandarin, these are the two characters for crisis. If you take these characters individually, it's danger and opportunity. The danger is real. I don't think I need to convince you of that. S197 is the opportunity we have to address this crisis. So our legislation has 3 goals, overarching goals: better health equity and fewer health disparities, and then decreasing the overall cost of care. This is the primary care triple superpower. There's ample evidence that shows when you increase investment in primary care, you get better health, fewer health disparities, all for an overall cost, lower cost. You get more for less. And yet in our infinite wisdom as a country, we've decided to invest about 5 cents for every dollar in primary care, for a healthcare dollar in primary care, where our peer nations are at about 15 cents. Okay. And so the way we hope to get there are through these 6 objectives. And I'm pretty sure 4 or 5 of these 6 are part of S197, doubling primary care investment, creating a prospective monthly payment instead of fee for service, removing copays and deductibles from primary care, financially incentivizing primary care transformation. The one concept that is not part of your legislation is removing primary care from health insurance, although there's some mention of it, and then establishing a primary care advisory body. This is our primary care advisory body. It was passed last year. We have a task force. I'm one of 25 members of this task force, and there's a whole long list of people to try and be very inclusive of all different stakeholders in this task force. I have sent these slides to Callista, so you will have access to these slides. And so what we're shooting for is a 3-year ramp to get to 15%. This task force is actually suggested an 8-year. We sort of compromised at 5-year. We still would like it sooner than that, but you can front load it. So we're working on that. There's a lot of momentum there. And this is an old slide. There's now like 25 states that are working on primary care investment and doubling primary care. We also have what we call our transformers. I call this primary care candy. This is all the stuff, if we had adequate resources in primary care, that we would want to invest in and offer to our patients in terms of advanced primary care services, things like integrated behavioral health, addiction treatment, health coaches, community health workers, group visits, all the good stuff that we could and should be offering our patients in a very advanced primary care way. This is our payment model. I think it's similar to yours. We take a baseline, we double it, and then we adjust that doubling based on quality, based on risk of patients, and based on the number of these transformers that people attest to adopting. Interestingly, in our legislation, exactly the same as your legislation, we are proposing a menu of 12 quality measures, of which a practice would choose 6. Of those 6, we're also proposing that 2 of them are based on patient experience, and that patients should have a large voice in determining what is considered quality. We also, like you all, are proposing that the risk of a patient, how complicated the patient, be part of the formula so that you're not incentivizing cherry picking where people exclude patients who are too complicated. But the problem with these formulas is that they only account for medical risk and not social risk. We propose a formula that accounts for social risk as well. So this is our Massachusetts, 7 million people, a few extra people compared to Vermont. We have 4 million commercial, 2 million Medicaid, and 1 million Medicare. Our 4 million commercial are in the 2 shades of blue on this slide. Why I'm emphasizing this is because the darker blue are the commercial self-funded plans. These are the employer-based plans. And ERISA law says that state government can't tell ERISA plans or employer-based plans what to do. So if you enact legislation creating a payment model for primary care and doubling primary care investment and doing all these wonderful things, it won't count for the self-funded folks. And for us in Massachusetts and for most of the country, that's 60%. So that wouldn't account for 2.4 million. Okay. So we have a workaround. It's called the Primary Care Stabilization Fund. This fund extricates primary care from insurance and assesses the insurance companies and some others entities, which we'll get to, and then pays the money directly to primary care. This essentially becomes direct primary care for all. Another way to think about this is single payer for primary care. In Vermont, in Bernie Sanders land, I think you all understand what single payer is. This is single payer for primary care. And we think it is the right way to manage primary care payment because insurance in any industry is for unexpected and catastrophic outcomes. Primary care is neither unexpected nor catastrophic. Insurance should have nothing to do with primary care. So the virtues of this fund are that it doesn't exclude the 60% of commercial patients who have employer-based plans. Delaware passed legislation that doubled primary care investment, but excluded the self-funded plans, the employer-based plans. Less than 20% of their citizens benefit. It hasn't moved the needle, and they really regret that they didn't account for this factor. So Albert Einstein said the significant problems we face can't be solved at the same level of thinking we were at when we created them. We need to do something fundamentally different if we're really going to solve this existential crisis of access and affordability and primary care. These are the 10 states that have reached out to us, and Hawaii becomes our 11th state from yesterday. That have reached out to us inquiring specifically about this primary care stabilization fund as a game changer in their primary care insurance. Of course, the elephant in the room, what you started with when you introduced me, is how do we pay for this? Well, we did a simulation looking at our legislation, and it showed that it pays for itself in 4 years by dramatically decreasing the cost of overall care, predominantly through decreased emergency medicine, unnecessary emergency medicine encounters, and unnecessary inpatient visits. we have other folks who say that 4 years is ridiculous, and it's probably closer to 1 year that it will pay for itself. Let's compromise at 2 years. I still haven't answered your question, which would be, how do you pay for it at least in the first 2 years, even if it's going to pay for itself after that? And this is our answer to that question. We think that commercial payers, large hospital systems, the pharmaceutical industry, and urgent care can all kick in a little bit to pay for primary care investment until it pays for itself. We think that that's a very teeny tiny haircut that they'll be taking, and it's very much in all of their interest to invest in primary care, because primary care dying is very bad news for these three bolded entities. The urgent care folks might not mind, but the large hospitals, the commercial payers, and the pharmaceutical industry needs primary care and should be willing to spend a few pennies to invest in primary care in that first year or two until this pays for itself. By the way, in the 10 years after, we project in Massachusetts $1.6 billion of savings conservatively. This is potentially a complete game changer. We have 24 folks who've endorsed this legislation that are on this slide, including our Massachusetts Medical Society and the University of Massachusetts healthcare system. And I'll conclude by saying that the current healthcare system is so broken, and we know it's broken, and the fundamental reason is because it's based on profit. And it's legislation that would allow health and equity at least to be on an even playing field. And I'll stop there.
That's a lot. Thank you.
It was a lot.
Yeah, so yeah, as you're talking through, I'm going to the slide on what about the first 4 years, and you're talking about some assessment on commercial payers or large hospital systems or pharmaceuticals. How does that look in terms of boots on the ground actually happening? What does that mean? Is there does your legislation have a specific fee or tax or on these different entities?
Yes, it would be an assessment. And it would be a temporary assessment on these entities, because if you didn't do any of this and you just said to the insurance companies, pay double now, but we don't want the overall pie to increase. How do you increase one slice of the pie and expect the whole pie not to increase? You have to expect that something's going to come down elsewhere in the pie. And but the point I was making is, if you say to the insurance companies, you're going to double your payment for primary care, well then they're just going to pass that expense on to consumers. But if you ask everyone to have some skin in the game, then and legislate that they can't increase premiums based on this increased primary care cost, that's how you control costs for consumers and not make it unfair for the payers to have to bear the whole burden, if that makes sense.
So in terms of administration, so in our state, we have our Green Mountain Care Board that oversees hospital budgets. We have a Department of Financial Regulation that work with insurance companies and rates, health insurance rates. And then we have our Medicaid, our public programs. Are you thinking about a separate administrative oversight for for Massachusetts primary care program?
Yes, what we're talking about there is the Primary Care Stabilization Fund that in our state would be overseen by our Health Policy Commission or our Executive Office of Health and Human Services. And perhaps the folks in Medicaid out of EOHHS would oversee this Primary Care Stabilization Fund because they know how to do that. That's what they do. So yes, there would be another body but it would be very low bureaucracy, right? Think about it. We're just passing money through from the payers to the practices. there'd be not all the bells and whistles that insurance companies have with prior auths and denials and all the things, they'd be spending, insurance companies spend like 30 cents on the dollar for that administrative cost of primary care. We would be spending like 5 cents on the dollar for administrative cost.
Right, thank you. I mean, that's similar to what's in our bill with DEVA overseeing this, our Medicaid folks overseeing it. What you are talking about also sounds very much like an ACO.
I see the similarities.
Yeah, similarity. Okay. One of my, Senator Benson, you asked your question.
Yeah, I just wondered whether you would share a copy of your draft bill if you have one with us, so we could just compare that to what we're looking at.
Of course. I sent Callista the PowerPoint slides, as well as a 2-page description of this primary care stabilization fund and the advantages of the fund. I can also send her the actual legislation.
That would be good. I mean, we've got the 3 things that you talked about on our webpage, but having the bill might be of interest. Thank you.
You bet.
I'm just curious, we heard testimony and you listened to it earlier about the federal money that's coming in. How is Massachusetts looking at those funds also in terms of setting up for this transition?
Yeah, I don't know the answer to that question. It's above my pay grade in terms of what Massachusetts is going to do with their rural transformation money. But I can imagine a mechanism by which some of the rural dollars, especially in Vermont, even more so than Massachusetts, could go into the primary care stabilization fund to help pay for this primary care investment until it pays for itself.
Okay, we have another question from our late council. Go ahead.
Hi, I'm Jen Carvey from the Office of Legislative Counsel, and I'm the drafter of the bill. Curious, when you talk about taking primary care out of health insurance, how that fits with the ACA requirements around minimum essential coverage and how plans can sort of comply with federal requirements while not covering primary care.
Okay, so there are legal aspects to ERISA. There are legal aspects to the Trump HR1 bill from July. And there are legal aspects with ACA. We have an attorney that is an expert on these things and primary care who prepared a memo for us describing how this legislation and this scheme that we just described is legal on all counts. And I could include that too, if that would be helpful.
That'd be great. Thank you.
Good work. That would be terrific. Thank you.
Will do.
I've gotta know the unexpected events. Sounds good. Any other questions from the committee? Dr. Altman, this has been very helpful to us. Thank you for sharing. And we may come back to you. I understand you also work with Stewie Zuri Song, and we'll probably be bringing him in at some point to testify as well. So appreciate it.
Dr. Song is a good friend. He also is the person who came up with the idea of the primary care stabilization fund that bypasses ERISA. He's one of the smartest people I've ever met. So I encourage you to do that. I'd be delighted to come back if I can be helpful, and really appreciate the work you all are doing in the great state of Vermont.
Well, thank you, and good work in the great state of Massachusetts. Okay, thank you very much. We're going to move on from 197. We've got a lot in our heads here, and I know that it feels like we're behind. I think we can accomplish everything we need to this morning on all of our bills. Do you have an interest in a 5-minute break, committee? I'm happy to go off.